Good afternoon, everyone, and welcome to the monthly Community Mental Health Transformation webinar. It's lovely I can see lots of kind of familiar faces as well as some new ones. I hope you can hear me okay. Thanks for kind of joining us this afternoon. So my name's Alice. I work in the comms team at Sussex Partnership, and I support the Community Mental Health Transformation Programme. I'm going to be your host for today's webinar. If you've not been to one of our webinars before, just a really warm welcome, and I hope you find it useful. So today we're going to be talking about neighbourhood mental health teams as momentum builds towards a coordinated go live on 10th of November. So lots of great works happening. It's very exciting. And we're also going to be talking about integrated care teams and neighbourhood health. Great session ahead for you today. I'm just going to share my screen and bring up some slides, so bear with me. Okay. So I hope you can see my slides. So before I get started and welcome our presenters, I will just talk through some kind of Teams tips. So the webinar's being recorded today, so it's going to be added to our YouTube playlist. So if you prefer, just please keep your camera turned off and anonymise your name. And to turn on live captions, click the three dots that say more in the toolbar on your screen and go to language and speech and select turn on live captions, and there'll be time for questions and answers at the end. So submit your questions in the chat or raise your virtual hand. So I'm going to give a warm welcome to our presenters today. So we have Penny and Martin, who are going to be talking about neighbourhood mental health teams. So Penny is Senior Programme Manager at Sussex Partnership, and Martin is the VCSE Transformation Lead for the programme. And we've got Colin Hicks and Jessica Tom, who are going to be talking about integrated care teams and neighbourhood health. So Colin's the Chief Strategy and Partnership Officer and Deputy Chief Exec at Sussex Partnership. And we've got Jessica Tom, who's the Managing Director at Sussex Provider Collaborative. Okay, so I am going to hand over to Penny and Martin to give an overview of neighbourhood mental health teams. So Penny and Martin?
Penny, is it okay? Shall I do this slide
Yep,
and then pass over
absolutely.
to you, Penny? Thank you. But thank you, Alice. Yeah, it's really great to see everybody and kind of really great to be part of these webinars as well. I think kind of we've recognised that in terms of kind of there might be some new people in attendance today kind of interested in the integrated care team. So we give the kind of briefest update in terms of the neighbourhood mental health teams before kind of handing over to Penny to talk about a little bit more detail around kind of recent activity as well. So as you know, part of the transformation is actually kind of bringing services, you know, the VCSE and statutory services, in this case, obviously the trust, much closer together, working in partnership as well for the betterment of the people who are using the services, but also kind of bringing primary and secondary parts of the system much more closely together as well. So our response to being for this in terms of Sussex has been kind of the development and the design of the new neighbourhood mental health teams as well. And you can see from our map, there will be kind of 15 kind of neighbourhood mental health services kind of launching on the 10th of November, which is really exciting in terms of it's kind of a huge kind of next step forward as well. So there's lots of activity, and Penny's just going to talk about some of those highlights on the next slide as well, that are going on as well. But we have real momentum and commitment from all parts of the system to really make this kind of a successful next step for us all as well. So Penny, over to you for a little bit more detail and exactly what activity is going on.
Thank you. Thanks, Martin. So just building on what Martin has said, we're really heading now towards a more formalised, I guess, soft go live in essence, to be able to work alongside our new electronic patient record system, so we can make sure the two things are able to complement each other. So there's lots and lots of work going on between those two programmes to help them work together and to make sure that they are helping each other and working alongside each other. So a big piece of work to make sure people are trained. We're working as much as possible on shared electronic record systems, because we know, working with our early implementer colleagues of community transformation, that's been one of their key indicators of success. So I guess that's the really big news at the minute, and there's a lot of time being spent on that. So that's really working through both the content and the processes of how we learn and utilise a new system. Within teams, within our 15 neighbourhood mental health teams now, there's a real embedding of shared leadership. And fundamentally, we're talking about between the voluntary sector organisations and Sussex Partnership, and working closely with our GP colleagues and having those meeting structures in place that support that integrated working. Some places that's more embedded than others, but everywhere has it on their must-do plan, and everybody is working towards trying to set up those meetings that support that type of working. So that includes things like multi-agency access meetings, which are a bit like managing the front door as a group, rather than people having to be referred in, declined, referred somewhere else, and all the things that frustrated people in the past. So that's building momentum and having some huddles where people can join an MDT 2, 3, 4 and up to 5 days a week for anything that needs discussing in a little bit of a more urgent way, and having a broader multidisciplinary team where other parts of the system that perhaps would function on their own, for example, people working perhaps out in GP surgeries, in the mental health teams, being able to come into those meetings and be able to work with the broader MDT to see if we can resolve any issues that may be coming along or support people in a different type of way. It's wrapped up in the service specification, which really is describing everything that we're trying to do. And that's coming towards a point of kind of final sign off. It has been a long, hard document, and it won't describe everything that sets us up for the next 5 years or so, but it will certainly describe where we are now and where we're aiming to get to. And that's really describing bringing those services together to make sure we can provide as much as we can for people in their local communities. To complement that, the standard operating procedure, so really helping teams, and this has been devised with teams and experts by experience, to think about how people can be really clear of their roles and responsibilities and how they physically work each day, where they're based, what activities they're responsible for, and all of those things that are critical to make sure a service is live and people are really clear on their tasks. We are also working on agreement to something called the care programme approach. So people on the call may or may not know this was the set of standards really set out around community teams many, many years ago, which has been updated, and there's a new national recommendation to work under a different framework, which is called the personalised care framework, and that includes some work around roles of the key worker or a named worker and who that may or may not be. So we're just doing some work around that at the minute. Unfortunately, nationally, the final guidance was due out in June, but it's been delayed till the autumn. So we're still continuing to work on those things, and we'll update you at a later meeting about where we've got to. And we've also started to look at all of the referral routes and processes and making sure people are really clear. We're still doing a bit of work on phones, etc., and which making sure it's really clear when people contact us that they are clear they've come through a neighbourhood mental health team, for example, looking at email addresses, etc. But fundamentally being really clear about how people are able to get in and what happens once they do get into a front door, wherever that front door might be. And as I said before, the new electronic patient record system, which is System 1, really working out how we can use that as much and as effectively as possible to really help support people and to bring together a core neighbourhood mental health team that really enables people to work with service users and professionals to care plan really well, and to make sure that we're able to work proactively together and really understand what everyone's doing. So with people at the centre of that, ensuring that people don't have a separate plan for perhaps something around the physical health needs and mental health, and something different for mental health needs, and something different for debt or employment or any other issues that a person might be facing, but able to really find and hold that information in a single space. And it's something that people we work with have told us for a long time that they find incredibly frustrating. It should also help us reduce the amount of times people need to tell their story. And we're also hoping that increasingly people will be holding their own records through the various digital innovations that are coming through systems. So that nothing about me without me continues to be a really, really core theme for this programme. And we will really continue to work with people to make sure they have access to all of their records and information, and they're able to hold their care plans themselves. That won't be perfect from when we go live, but it'll be a long-term ambition that we continue to work through and be able to reach. And of course, as with other issues on or other pieces of work on here, we'll continue to keep updated as we go along. We are still really, really optimistic that on the 10th of November, in line with our electronic patient record system, we will formally go live as those 15 neighbourhood mental health teams. And as I said before, that doesn't mean it'll be perfect from that launch, but what it does mean is that we'll have meeting structures set up in place. We'll have staff allocated to those right neighbourhood mental health teams, and we will have started to be working much more collaboratively as a system in order to support people. We do recognise that not every single team has exactly the same thing on offer, and that's for lots and lots of historic reasons, but we're of course still trying to work through those to make sure we eventually end up on a more sustainable and shared level of resources across all of our teams. So that will take us a little bit of time. And we will then have a action plan that will help us work through from November, after that first initial go live launch, through to April, which will help us really identify things we need to continue to work with. And that includes things like our wider or aligned services. So how do we work much better with substance use services? How do we work much better with housing, etc., in an even more of a collaborative way? And we will be able to formalise some of those structures in between those times. And we'll be able to review the EPR, the new electronic patient record system, and see how it's working. And then, of course, we'll work on a further plan, so a continuous improvement plan, so post April 26 and throughout that next year. So programmes of this size obviously take lots and lots of time to bed in, and we know from early implementer colleagues from the point they've kind of formally launched, it takes probably a good 3 years to get to exactly where we want to go. So that's where we are at the moment. And of course, one of the exciting things that's really, really been interesting for us and really helpful is starting to really work alongside the integrated care teams about how we can further collaborate. So how all of the time we're working in a much, much more collaborative space for people, so we can really continue to serve neighbourhood teams in line with the NHS 10-year plan. So with that link in mind, I'm going to hand over to Colin and Jessica. Thank you.
Thanks, Penny. Yeah, that was a lovely segue. I'll hand straight over to Colin and Jess to talk about neighbourhood health. Over to you.
Thanks both, and thanks everyone for kind of having us today. So I guess what Jess and I want to do, probably just in sort of 10-12 minutes or so, is just give a bit of a flavour around the developments that are going on within the system, around the kind of the integrated kind of sort of community teams or integrated neighbourhood teams. You'll hear them termed differently, and just think about what does that mean with regards to the work that everyone is so involved in terms of sort of the neighbourhood piece as well. Next slide, please. So just in terms of context, and I apologise, there's quite a lot of detail in some of these slides, but we will obviously make sure that everyone has access to them outside of here, but they're more of a kind of sort of I guess, a reference point. So one of the things that we know really, really clearly in the 10-year plan is that there's a real central focus around developing a neighbourhood health service, a neighbourhood health sort of system, if you like. You hear it when you think about the reference to sort of the Darcy shifts, when we talk about, sort of from hospital to kind of sort of to community. And as we've seen within the kind of the planning guidance that's come out from NHS England, there's a real strength in looking at how do we start to organise our services across health, but in partnership with the voluntary sector, with local authority and other partners, to really kind of focus on communities of populations around 50,000. And really help to think about devolving responsibility for or empowering communities to make decisions around how do they want services organised around them, and how would they see their kind of priorities and sort of preferences. So within Sussex at the moment, as nationally, what we're all working to do is to look at how do we develop a neighbourhood model of care across what is a very complicated and fragmented, I guess, health economy at the moment. You know, at the base units, you've got GP practices that are organizing themselves into sort of PCNs, and we're now looking at these ICT footprints. You've got a range of big NHS providers, ourselves, SCFT, UHSX, ESHT, etc. And then you've got, particularly in Sussex, an incredibly kind of vibrant and diverse voluntary sector as well, supported by the 3 local authorities. So how do we start to bring those different organizations on different scales together so that we're really thinking about individual kind of populations? And as Penny pointed out earlier, one of the critical things here as well is thinking about designing the ICTs and designing the neighbourhood mental health teams on the same geographical footprint. And that, please do not underestimate the challenge of even getting to that point that the team have really done, but that will absolutely help accelerate things forward. Next slide, please. So I think it's really important that what we don't do is we don't redesign services in silos. So there is a danger that within mental health, because we had the community mental health framework a few years back, that we start to design a kind of a reimagined community mental health offer with much stronger links to primary care. But what we don't want to do is to do that in isolation of thinking about the sort of the neighbourhood model for physical healthcare, which is more strongly kind of articulated in the 10-year plan. And so what we're trying to really, really sort of think through is this idea that actually what we're trying to create is a neighbourhood health offer that involves both physical and mental health care for people of all ages within that particular community. That's the aspiration. We're a few years away from it, but that's absolutely where we're aspiring to. We want to make sure that we can demonstrate that there is equitability, there's holistic access to it, and that we're really clear and addressing historic entrenched health inequalities that we know that we see across all of our kind of sort of populations. And so, in essence, you know, we've got the ambitions of the community mental health framework, and I think we can take a lot of the learning from that and really think about how that helps us to start to establish our integrated kind of community teams on those sort of similar kind of sort of footprints. Next slide, please. I think the why is really, really important. And I think, you know, lots of us know this because it's bread and butter for us, but lots of partners and stuff, I think this sort of really starts to bring it into shape. So we know that 30% of people with a long-term condition such as diabetes, COPD, etc., will also experience a co-occurring mental health problem. And we know that something like 46% of those people with a mental health problem will also have a co-occurring physical health long-term condition. So there is a huge intersection for a significant group of people between their mental health and their kind of sort of physical health. And we know as well that, you know, we know that people with SMI, people who have serious mental illness, face one of the greatest health inequalities. And actually what we've seen over recent years is that inequality is actually growing rather than improving. And often that disparity is most fundamentally linked to access to physical health care for people who often find accessing services quite sort of challenging. We know as well that actually we can see some really significant improvements in people's long-term conditions when we attend to and pay attention to mental health care. But we also know that quite often people will present with a physical health complaint because for them that might be more accepting than to think about it within the mental health kind of sort of territory as well. So for me, there's something around really recognizing people as a holistic entity that have both mental and physical health, both poor and well, but also thinking about how do we then start to join up our offer so that actually we're more aware within the mental health sphere about people's physical health needs and are able to quickly identify, refer on, seek support. But also, how do we make sure that our physical health colleagues are really kind of attending to and paying attention to the mental well-being of the people that they're seeing, are easily able to spot or screen signs of either common or more serious mental health issues, and then able to draw that support in so that it feels seamless and wraps around an individual rather than, you need to go to this other team and another building, it's over here, and we're going to badge it mental health, which for some people can still be incredibly scary, despite all the work that gets done around supporting or trying to kind of sort of address some of the taboos. So I think I'll pass over to Jess in a second, but I guess the kind of the key message for me is that nothing that we're talking about in terms of the ICT derails, cuts across anything that we're doing in terms of the neighbourhood mental health team. It's about kind of enhancing and building on that so that we're really starting to think about, that parity piece around people have mental health and physical health. And actually, if we treat both together, we will absolutely deliver the best outcomes for those individuals and therefore their communities. But Jess, do you want to talk a bit more about what's going on in Sussex specifically?
Thanks, Colin, and thank you everyone for inviting me along to talk. So I won't repeat what's written on quite early slides. As Colin said, we will make sure everyone has access to it, but just to kind of follow on the conversation. So what does this mean for us in Sussex in relation to what we've just heard in terms of the progress for the neighbourhood mental health teams, but where we're looking at our integrated community teams, which involves mental health as well as our physical health. So we are in the process of setting up what we are focusing on our population cohort from October, and the geographical footprints, as Colin and Penny has articulated, do align with the neighbourhood mental health team's footprint. So we have 13 named ICTs across the Sussex patch. In Brighton and Hove, they have one big ICT business unit, but they do separate out into 3 strategic leadership groups that align to the neighbourhood mental health teams. Those teams involve all of those partners you can see on the slide. So we have from public health, local authority, voluntary sector and our hospice partners, as well as our primary care colleagues, community colleagues and our acute colleagues that work across. They meet regularly to discuss improvements in their population area and how we can further work to align. The work that we have been doing this year has been focusing on how we can take a population health management approach to really start working directly frontline staff with our patient cohort. And that population health management approach is we're using a particular tool, which is called the John Hopkins tool. Some people in data world may already know it, but it will enable us to look at our population and focus on a population cohort to start working. So we recognise the journey and our aspirations to work with all of our population in this way, but we're also keen to start doing something. And from October, the work that we will be doing with our population with our most highest and ongoing needs. So that kind of overlap population Colin just showed in the slide before, and working with that population. So if we could go to the next slide. So what does this mean in practice for our frontline colleagues that will be working together? Is we have agreed to work around some core principles. So no matter who you are as a citizen, patient, cohort, when you access this new way of working, these are the core principles that we should be all working to, no matter what organisation you work for. And you can see that a lot of that is around kind of being patient focused, not working to organisational boundaries, but focusing on patient needs, having open lines of communication and being flexible and adaptable. So there's a lot of work that is going on behind the scenes of how do we enable and do the workforce activation so that our colleagues can feel that they are able to work in this way. So a lot of the work that has been happening within the ICTs is forming those relationships and focusing on how we can put that into practice. So if we could go to the next slide. So this is just a kind of diagram image to try and show the overlap and how we are planning and how we are working together across the neighbourhood mental health teams and the ICTs, and recognising there are multidisciplinary meetings with shared goals and accountability, care plans based on individuals. So the technology, we're still working on some of the systems, etc. But the point being is that we're all aware and we're all working towards these principles. So when we are working with our patient cohorts, we are able to interact. As an example, if our local neighbourhood mental health team already has a MDT in place where there is a named citizen or patient that we know also has physical health, instead of going to additional MDT, we can bring that conversation to there and make sure that we can access the right planning and support for that patient there, and vice versa. So if we go to the next slide, this is just an illustration of trying to kind of bring to life a citizen patient story of what neighbourhood health working is aiming to do. So if you take David's needs as an 82-year-old retired armed forces veteran, he lives alone. He's got multiple long-term conditions. He struggles with mobility, alcohol use, and mental health. And he has his daughter as a main carer, but she's also feeling quite overwhelmed. So if we look at what the needs of David's is around having consistent, trusted professionals that are able to understand and know his needs, joined up care so he only has to tell his story once, and support for his needs around his mobility, his alcohol use, and his mental health. So there will be help that he will need in terms of connections to his community and the wider care, wider support, but also support for his daughter as his carer, and the help in terms of daily living and housing and finance, etc. So if we put that into our new ways of working around integrated community teams, we're aiming to have one digital care record. So any professional working within that area would be able to access David's needs and see what's in place and where there's any gaps or changes that need to take place. We will be taking a proactive, holistic health review. So there will be a multidisciplinary team around his reviews and what his needs are. Referrals if he needs to go into a particular service or needs something without necessarily having to go to his GP. Social prescribing and the voluntary sector links is really key in terms of his well-being, in terms of his physical and mental health, and education element in terms of that preventative, so how to manage his health at home. Collectively, the aim would be that David feels known, that he feels heard and supported, and he's able to live well in his community. So that's just an illustration of kind of bringing what we're trying to do to life. If we just go to the next slide. So here is an illustration of who's in the kind of the ICT teams, and you can see that there is a multidisciplinary team coordinator, so somebody who will be able to coordinate the population management list of patients to focus on. They will coordinate and make sure that the right professionals and teams are coming together to talk around those patients, but also that they're tapping into the right MDT and collective meeting. There will be GP and practice staff. You would expect to have a district nurse, fertility practitioners, therapists, mental health practitioners, social work, the voluntary community sector in relation to that patient's community, because we have a very large community and voluntary community sector in Sussex. And there would also be additional roles, as you would expect, depending on the patient's needs. So we're talking about housing and hospice, if we're talking about palliative care, etc. So it's not a set list. We expect that the team will be different depending on what population cohort teams are working with, and also depending on which area we're working in. So it should be flexible and removable, but we want to ensure that there is a core coordinator to ensure that we are working with that patient cohort. So I will stop there, and I'm sure Alice will take over to invite any questions for any of us.
Yeah, thank you so much, Martin, Penny, and Colin, and Jess. I'm going to stop sharing my screen so we can see everyone and open up the the floor for questions. So I'll just stop sharing. Okay, great. So does anybody have any questions? So Michael.
Good morning.
Good
I've got a
morning.
really general question. It sounds very constructive for patients and their relationship with the NHS. What are the perceived or potential benefits for the VCSE? How are they going to be motivated to engage in this framework?
Great. Thanks, Michael. Does Colin or Jess want to kind of respond to Michael's question about BCSE involvement in ICTs and neighbourhood health?
Jess, do you want to come in about the Alliance?
Yeah, sure. So, firstly, it's worth just kind of so this piece of work is covered under the Sussex Provider Collaborative, which is a collaborative of all of our NHS partners in Sussex, including Primary Care Provider Collaborative. And we have also extended this out in terms of working for Neighbourhood Health to cover our Hospice Alliance and our Voluntary Sector Leaders Alliance, which represents all the voluntary sector across Sussex. So we have formed a kind of programme board with a merged shared leadership to ensure that our voluntary sector, our local authority and our Hospice Alliance colleagues are all part of shaping and designing the work that we're doing. And in addition to that, we also have with our ICB colleagues within the future planning the need for us to form a neighbourhood health alliance, which means that we will kind of be contracting in this way to work together, which will further include our voluntary sector and our hospice and local authority colleagues. So there's twofolds really. There's one in terms of collaboration and working together collectively. We have those mechanisms and governance in place to do that and shape that together. And going forward, there's also the contractual type of element of how we are expected to work together, where we will be held to account to show and demonstrate that. So I think there are two forms that are taking place. We meet regularly with our voluntary sector colleagues who are part of all of our governance from strategic level to frontline level. But I do recognise how large our voluntary sector is. So ensuring that every voice is heard it continues to be an ongoing way of working.
Thanks, Jess. Gillian, you've got your hand up, and then I'll come to some of the questions in the chat as well. But
thank you. I think it's on a similar theme to Michael's query, is that in the absence of a social prescriber, who would you identify as the BCSC representative in supporting an individual, taking that holistic, person-centered care approach?
okay, Colin or Jess, you got any thoughts in response to Gillian?
Yeah, so I think at the moment we are at the early stages of designing what those local kind of sort of teams should start to look like. So we've just agreed literally in the last few weeks about the kind of focus on frailty initially and starting to bring some of those kind of sort of partners together. What we need to understand, and I don't think we have a real kind of clear lens of yet, is what is already in existence in each of those different ICT geographical kind of sort of footprints. And we know that we've got huge variation. So we've got lots of areas. We've got some of those footprints where there is a real strong presence of social prescribers, of other voluntary sector roles. We've got areas where we've got some real strength in the voluntary sector roles that we've put in through a mental health route. But we will need to understand where there are some of those kind of sort of gaps, and then work with those local ICTs to think about how they want to then start to think about the skill mix associated with it. So I think it is a work in progress rather than an absolute sort of definitive. I think the other thing, just to add on to what Jess was saying, was that over time the aim is that those local ICTs will take more responsibility for being able to kind of sort of commission what they want. And I think that will also offer us a real opportunity to think about, we know that our voluntary sector operates like a, sort of pyramid almost. We've got some very large national organisations that operate within the Sussex footprint. We've also got some, incredibly valued, very sort of small kind of grassroots type organisations as well. And I think there's a real challenge around how do you get the plethora of that voice into the conversations at the moment. I think as those ICTs start to become a thing, an entity with a person leading them, actually, I think there then becomes more of an opportunity to think about that really local kind of local conversation around a voluntary organisation that may or may not operate, across one or two of those kind of geographical areas. So I think it is in there. It is in there at the table, but I think there's a lot for us to do to try to kind of continue to do this, because the success will be is if this is not just an NHS thing. If it's just an NHS thing done by NHS partners, this won't work. And I think there's an absolute commitment to that.
Thank you.
Thank you. Neil, would you like to ask your question?
Yeah, so I was really intrigued by sort of the ICT and the leadership of it. So I know there will be a coordinator in each one, but I suppose it's just a general question. So there's two bits to it. One is, when an ICT comes together, is it a pulling together of the various bits of funding? Because at the moment they're all quite disparate. So I imagine there's going to be sort of pulling together of a funding package, but also in terms of who might be leading that as that coordinator role. Not saying it should be the voluntary sector, I don't think it would be, but actually in terms of, because I think the real success of this is that leadership, but you're pulling together quite disparate groups of people as well, and we've experienced that, through trial and error with the Neighbourhood Mental Health teams. But who do you imagine is going to be leading that? Who's going to employ them? Who's going to host them? Because I think that's quite key for me, trying to conceptualise what this actually means in reality.
Jess, I can see you nodding away. Do you want to come in?
Yeah, great question. It's one I've just had a debate within the East of Sussex just this morning. So I think similar to what Colin said, we are on a journey. It would be great if we could do this overnight. We can't. So I think for us to be able to mobilise something from October, which is our current goal, we want to start working in our ICT footprints for our highest and ongoing needs patient cohort from October. We have been taking quite a pragmatic response to that, which is who will be able to access the health management tool information. So how do we get that data safely shared with a partner organisation person to start doing the work? So for a lot of our areas in our ICT footprints, it will be a NHS employed coordinator, as in somebody who's already has part of that within their role and scope. However, saying that not everybody does, as you can imagine, and we're not in a position to start sorting out lots of technical contractual stuff. So what we have done is say where we have capacity across any of those partners within the ICT footprint to take on that coordination role, whether it be from the voluntary sector, our local authority colleagues, we have just reached out to those people to say, can we? So I think in going forward on our journey, I think the ICTs themselves will decide who's best placed to take on that coordination role, because I'm sure that role is going to grow as our patient population and cohorts that we work with grow, and we would expect it to be quite varied and not to be a just an NHS role. Otherwise we're not going to get the full strength of working in this way. But to start with, in October there will be predominantly NHS roles that will be kind of used to manage that post, but I can't see that being a standard thing that would just carry on. It will change. We expect it to change, and we would want it to change.
Fabulous, thank you. Jo, you've got your hand up.
Thanks, Alice. Yeah, a couple of questions. Firstly, I was it's brilliant to hear about the development, and also heartening to know that it's going to be really integrated with the ICT development over the next couple of years. I was interested in the slide that Colin presented about the overlap between mental health and long-term conditions, and wondered, I know that was national data, but I wondered, is that known in terms of Sussex? Do we have a real sense of where, what the overlap is here in Sussex, and how does that pan out across the footprint? So that's one question, and I'll just put my other one in while I'm speaking. My other question, I lead the Changing Futures programme, for those of you that don't know me, and I'm really interested in adults with compound needs and cross-cutting needs, so co-occurring conditions, etc. I just wondered, will there be a health inclusion lens brought to this work? I know we're sort of having some early discussions with ICT development around that, but I just wanted to ensure that is in the thinking, because I think often people in those groups are very, very disadvantaged in terms of accessing the support they need.
Fabulous, thank you. Colin?
I was going to say, shall I go? So in terms of your first question, I'm not aware I've seen anything in any of the JSNAs particularly kind of sort of clearly articulated as that kind of sort of national data is around the kind of the prevalence and sort of the overlap. And I've certainly not seen anything coming out of the sort of the local GP records. It's something that we should be able to get access to through some of the digitization of stuff. And I do think, particularly for us, one of the big drivers for us to move from care notes onto system one, which I absolutely recognize is a monumental challenge for everyone, is we will be on system one, for which a large number of our GP practices are also on system one, as are some of our main NHS provider partners, which means understanding the data across populations, and particularly understanding things like service utilization, will become a lot easier. So I don't know, we do, Joe, I've not seen it at a Sussex level, but it should absolutely be something that I would want to see. And I think we've got some data packs at an ICT footprint, which are really helpful. They're a sort of starter for 10 that really clearly say, this is what this particular ICT's population looks like. This is what we know that in terms of protected characteristics, deprivation. What we need to build out is, okay, well, what does that look like in terms of diagnosis, because that's the framework that we have, kind of sort of have to use. And then how does that translate into health utilization? And critically, what's the experience and what's the outcomes that people are receiving as kind of sort of part of that? In terms of the second part of your kind of sort of question, then yes, I think it's absolutely critical. And I think it was interesting. So Catherine Saunders is kind of heavily involved in all of the ICT kind of sort of development work. And I think it was literally just before she went on leave, she was referencing the kind of the work of the program, and almost actually how do we draw that in and how do we think about some of those kind of sort of relationships as well. I know in Brighton, there's been lots of conversations around, when you think about multiple compound needs, do you think about an ICT within the 3 footprints, or do you think about an ICT that supports a population? Some really interesting kind of conversations with Chaz and others. So yes, I think it has to be there, but I also think, it's one of those things people need to kind of keep challenging us to make sure it stays front and center in the conversations.
Thank you. Penny?
Thank you. Yeah, it's not really a question, more of a comment, I think. And I think the learning we've had through the NMHTs, which I know the ICTs are as well, is it's really such a relational model. So that relation and those collaborations then come from that on the ground, getting people together as much as possible, trying to say yes more, working out how we can work together in local teams all of the time, has helped us really build that collaboration. And the second bit really is around that relationships and culture in the context of making sure VCSE colleagues are around the table, equally around the table with everybody else, so we can really have those discussions. And I think in NMHTs, that's been one of our biggest reflections and our biggest causes for success, where we've had local voluntary sector providers that really know their communities, that are out in the communities, that are working with those small groups, that are working with people with multiple compound needs, etc. And so for me, I think ICTs are really pleased to hear that joint leadership in terms of, as we grow and develop and move forward, for leading ICTs will be a shared one, because I absolutely think the more we do that, the better results that we get and the better collaboration we get. And I think that's critical and something that we continue to try and do within mental health services, and hopefully something we can really help with in terms of the development of those ICTs, because I think as a group of providers, NHS with VCSE lead providers, we've probably got quite a lot of kind of contacts and relationships between us that we could really help move things forward with. So just really an exciting time. We know it works, but it's that the thing that I think we've learned more than anything is the cultural change is big, and people feeling safe and people feeling able to share that information with perhaps potentially a bigger team and all of those things. But the outputs that we're starting to see and some of the feedback we're starting to get is very positive.
Fabulous, thank you. We've got a couple of questions in the chat relating to representation in integrated care teams. So from the MSK space and for creativity for health. And I think Colin and Penny have kind of just touched on that, saying it's a journey of development. Is there anything you'd like to kind of add to previous comments around that representation of lots of different organisations?
Nothing specific for me. I think the bit I think there's an interesting piece at the moment is so from within the mental health space. I think we have developed a really sort of strong network within our sort of voluntary sector kind of sort of partners. I do have Karen and Neil front and center in my screen as I'm saying that as well. So I'm making sure I'm getting no cross looks from either of them. I think it's interesting when we talk about the voluntary sector alliance that's been sort of established from a physical health perspective around what we don't end up doing is looking in two different directions when we start talking about the voluntary sector. So I think there's a danger that we've got a really strong relationship through all the work that we've done over the last kind of sort of 3-5 years. Lots and lots of leadership within that. How do we make sure that we don't sort of look left for voluntary sector engagement to do with mental health and then look right for voluntary sector engagement to do with physical health? Because I think we will then run the risk of kind of undermining the total value that all of our partners kind of sort of bring. So I think there's another step in this kind of sort of evolution that we need to take. But I absolutely think, what we want to do is we've sort of commitment, and it will take a bit of time, is get those decisions into those local teams. So those local teams understand their populations, they really understand what's going to work in those local communities, and then maximising community assets as well. So that we don't always just think about this from a deficit model, but we do think about it from an asset and strength model as well.
Fabulous, thank you. And we've got a couple of questions relating to one digital care record that Penny, you mentioned kind of earlier. So what will this mean in terms of SPFT records? Will the entire record on System 1 be accessible by non-SPFT ICT members? And how would we address kind of digital inequalities from people to access their care record? Penny, I know it's a big question.
It's a big question. So where we've got to, obviously we've done a lot of work at the moment in terms of the NMHT and the electronic patient record system, that being System 1, particularly around making sure people know when they come into a system and they're being referred into something, they know what it is the something is that they're being referred into. So yes is the short answer. The EPI is a shared system, but there are an enormous amount of guidance and protection that sits alongside that. So any information that's accessed that shouldn't be accessed is obviously it's closely monitored, and it would be picked up for information sharing agreements and arrangements, and where any access happens where it shouldn't happen, that would flag up, and we would be able to see where somebody's been accessing something or whatever that something might be. As we work at the moment, so that's the same way that we work now. So we do have lots of safeguards in place to make sure information isn't shared when it shouldn't be shared. So people should only be looking at things for the care planning purposes that they require, and nothing more than that. And we will continue to safeguard those things. And so we're endlessly working, as we should be, with our EPR, our electronic patient record colleagues, and with our colleagues in data protection to make sure all those rules are followed and all those agreements are indeed in place for people, so they know, one, exactly what they're accessing, how their data is stored, and how it's protected. So I don't know if that helps. It is a big question, and there's obviously lots of complexities within that. And I know we've talked a lot in Neighbourhood Mental Health Teams about consent, and we will continue to do that. And we've done a webinar, haven't we, similar to this around that, which we can revisit again.
Can I just jump in, Alice? Because
of course.
So I absolutely agree with everything Penny sort of said, and it is an area that we know that there is often a lot of anxiety associated with this around information sharing, and there's a lot of work going into it, etc. I also want us to just kind of sort of recognise that one of the biggest challenges that we often get in terms of complaints about healthcare is around the fact that it is not experienced as being joined up. So we continually hear the bit around, I have to keep telling my story again and again and again. Or I can remember working with someone once who clocked it. She had on an average day, she had 4 different health practitioners coming into her house at 4 different times to do 4 different procedures with her, mental health and physical health. None of the timings were coordinated. One of them was constantly telling her that she needed to get out and exercise more. And she was there going, but I can't get out and exercise more because I've got to fit 3 other appointments in today. and none of you know when each other are going to arrive, or actually it's it was only in a conversation with my diabetic specialist nurse did I start to disclose that actually I was struggling a bit. I just wasn't quite functioning. I wasn't looking after myself as well, and actually that didn't get shared with anyone else. So I think there's always that really difficult balance between absolutely recognizing the importance around consent and understanding how information is used, but we've also got to really kind of keep an eye on the fact that the best care we can give people is when care is joined up, and when we're working together for those outcomes for individuals. So it's a tricky balance, but just at the moment we've got people who receive multiple visits from multiple teams because people don't know what each other's doing. That can't be the best care that we're able to deliver for people in Sussex.
Okay. Thanks, Colin and Penny. I'll just, we've got lots of questions in the chat, so I'll just read out one more and then come back to the room. So Tyler's kind of asked that it was mentioned earlier that it's been co-produced and the experts by experience were involved. So the co-production of the Neighbourhood Mental Health Team model, and Penny's kind of responded to say, yes, very much so. Colin, Jess, have experts by experience and that kind of lived experience, kind of insight, been involved in integrated care teams and the development of the neighbourhood health concept?
Jess, do you want to come in?
Yeah, sure. So I would say on reflection, we haven't done as good a job in aligning as with the neighbourhood mental health teams in terms of experts by experience. What we have done at ICT level, and every ICT has approached this differently, have involved their patients, their citizens in how to formulate their teams and come together. So where we've then kind of gotten that as our foundation, we've kind of jumped into, okay, we want to start delivering something as a core kind of service in October quite quickly. So we've kind of skipped into that. And so I think it would be fair to say that actually we haven't kind of really spent a lot of time with engaging our citizens around saying, is this the right cohort in your ICT area to work with as a core across? But that hasn't gone without being recognised. So what we have done as well alongside that, and we've asked the National Association of Primary Care, who have been doing a lot of work with neighbourhood health across the country, to come in and work with us around, now we've got the establishment of these ICTs and we're delivering from October this kind of core offer for a particular patient cohort. How do we now meaningfully engage with our service users to kind of set what we want as our outcomes, set what we want as our ways of working and delivery? So I think it goes back to, we're on a journey. I think it would be unfair of me not to recognise that we haven't taken the exact same approach, but it's not to say that it's not happening and we're not doing it. So I think it's kind of a parallel piece of work that's going on.
Fabulous, thank you. Sue, you've got your hand up.
Hi, yeah, thank you. My name's Sue. I'm part of the Brighton and Hove Lived Experience Advisory Group. I'm also part of the transformation, the partnership group transformation, and I have a query about the outreach and about the groups that you have as part of the CSE. The groups that I see that are part of the partnership group meeting are not varied and are not diverse in attendance, and I'm just wondering how that will affect clients, users of the service. For those ones that find it hard to step into the service, how is that going to affect? Are you going to do more outreach that will reach those groups that aren't currently being reached? Or does that make sense? It's to do with Muslim, to do with Chinese, to do with some Afro-Caribbean countries. I'm just wondering how you're going to outreach to those groups to make it more applicable for them to come into the service.
Yeah,
because
thanks.
at the moment they're not. So I just wondered how you're going to do that. Thank you.
Thanks, Sue.
Sorry, Alice, can I just mention to something Jessica's just said about the co-production at the beginning?
So, Sue, could you just put your mic on mute? We've got some feedback coming through. Or somebody else who's got some feedback coming through?
I'm not sure that's coming from me, Alice. But I'll turn it off anyway.
Okay. Pat, it might be because you're walking. I'm wondering if it's that. But did you want to pop your question in the chat? It was just quite hard to hear you coming through. So just in response to kind of Sue's question around kind of addressing all the diverse kind of communities that we have across Sussex in our neighbourhood mental health team model and the development of that kind of neighbourhood health kind of concept. Penny, did you want to kind of come into that?
Yes, it's endlessly a challenge for us to reach, you know, all people in all of communities, and we know we need to continue to work with them. So we work a lot with the leads of 3 groups that we have, which are lived experience groups, and we work with them to try and reach as many people as they can through their networks for us to be able to try and engage as many people across communities as we possibly can. VCSE colleagues might want to come in. They've done lots of work within local communities about directly and actively engaging people through lots and lots of different projects across the county to be able to both support those individuals but also understand their needs in a greater way. I think there's always more to be done, so any ways we can do that better, more of, we will continue to try and do so, absolutely recognising it's the voices that we don't always hear are the ones that we want to hear from in an increased way alongside everybody else's voices, of course. So I don't think there's an easy answer to this other than we do try and work with all of our local contacts to reach as many communities as we can, but absolutely recognise it's a diversity in communities as well as people on the range of their mental health journey and different people who've experienced different things. It's often a little bit complicated to try and get to every point to be able to really understand that. So to do that, we work sometimes with SPFTs working together groups who go out and actively are seeing people that are perhaps there and then in the midst of receiving some care and treatment who feel able to work alongside us, and sometimes that's from people that are perhaps further along in their recovery journey. So we do try and reach a range of people, but absolutely recognise we don't always get that right. So but it is something we continue to work on and are aware of.
Thanks, Penny. Michael, come to you next.
I'm very aware that the software that exists within the NHS is something that most VCSE organisations are not exposed to on a daily basis. And I think the journey that most of them will need to undertake to ensure that their volunteers and paid employees can effectively engage and recognise the sensitivity of the nature of data which is being exposed through the need to support patients is something that a lot of people won't have experience of. So training and support in that, whilst having a financial element, really needs to be proactive and provided in such a way as it has an ongoing element rather than just here's a 3-hour course, you do it at home and fingers crossed.
Yeah, absolutely, Michael. We've talked quite a bit about consent and that kind of patient consent in these webinars. I wonder if Martin might want to come into this and ask, who's our VCSE lead for the transformation programme and engaging and working with voluntary organisations as part of the programme as a whole. Martin, did you want to kind of come in and or Penny and then ask your question as well at the same time?
Yeah, I think mine was originally a bit different than Michael's point, but we'll try and cover that as well. I just wanted, in terms of kind of, there was a question around kind of valuation, and I was wondering, given the time as well, to kind of piece those two together around lived experience. So what the kind of thing we're trying to develop is that kind of valuation, that quality framework that sits with the neighbourhood mental health teams going forward. And a part of that will be kind of evaluating kind of how that neighbourhood mental health team is responding to its population needs as well, picking up on Sue's point, but also about how do we actually do kind of quality evaluation as well. And what we want to really consider and kind of what we would like to work towards is actually having people that are going out doing these kind of quality assessments, but actually having people with lived experience also being part of that team that goes out there to making sure there is that critical eye, that kind of, that critical friend in terms of how those services are responding to people's experiences. There will be lots of data around performance, how well it's doing, but it's also really, really important to making sure that there is that, how do people experience this service? Is it actually working for them, meeting their needs as well? So we're hoping, like you're saying, kind of have this early kind of softer launch and then develop the service kind of going forward as well. And just to kind of a quick reference to making sure that we, that to reassure Michael, I suppose, that we are kind of having these conversations, trying to join up these kind of systems and that safety and kind of, that confidentiality around support as well. So there's an ongoing commitment that maybe we could pick up another time, Michael. I'm conscious of time, Alice.
Yeah, thanks so much, Martin. As we've gone over, I wonder, Esther, would you be able to put your question in the chat and all the other questions that we've not had time to talk about? We'll promise we'll go back and we'll kind of answer them after the meeting. So just I can see lots of people are dropping off because we've gone past 1. So I'll just say a big thank you to all the presenters and for everyone coming along. It's been a fantastic session. Hope you can come along to the next one, 24th of September, where we'll have local representatives from our 15 neighbourhood mental health teams really kind of sharing an update on progress so far as we get to that countdown of November the 10th to go live. So yeah, huge thank you again. Have a lovely afternoon. See you soon. Take care. Bye.
Thank you. Bye-bye.